All right. So we just went over. Welcome back. Ooh, what'd you get?
Ooh, what is that?
Right, I just want a rabbit. I like a Paloma, so I'm gonna craft myself.
Ooh, I like the can. It's cute.
So,
Cute.
Shania, since you missed it, give me 2 indications for transfusing of.
Love him a little bit.
Love it? Give me one more.
Oh, is that too?
Give me like a couple vital signs.
Low blood pressure, maybe.
Yeah,
Or
sure. Maybe.
Khaki, if they're like dehydrated, they might need if they're experiencing volume loss.
Okay. What's another one you might see if, so we have low blood pressure if they're hypovolemic as well.
Right.
Tachycardia along with that. If they're severely, what sort of sign might? Pale, yeah.
Weakness.
Weakness. Maybe exhaustion.
Yeah.
Yeah.
Might be blue, fingertips and stuff.
Yeah. So this slide kind of goes over that here. So some reasons. So bone marrow failure due to, there's a bunch of different reasons. It can be an issue with nutritional status. It could be cancer. It could be literally, so if we straight up remove, like if you break your hip and we have to remove part of the femur to replace it with a titanium, something or other. Chronic disease such as renal failure, we just went over that in class.
I just realized I'm about to leave. School trash.
Oh, you're okay. Blood loss is the big one. That's where you're going to see the most clinical symptoms, followed by red blood cell destruction. We talked pretty extensively about the red blood cell destruction part of this in class with both cancer as well as during our liver section. What could cause excessive red blood cell death?
Oh, excessive red blood cell death.
Sure. There was one in particular that we talked about during liver. With the excessive bilirubin accumulation. It causes jaundice.
Just cirrhosis?
Yeah, because it's all the trash circulating around the body. Yeah, I need to read more about that. I was hoping someone else would know.
What was the question?
What's another thing that leads to red blood cell death systemically? Yeah. So there is a condition that causes the cells to die early. That's
Is it
not
some sort of anemia?
it's a hemolytic anemia, but you don't just like something has to cause it.
Sickle cell?
That is a type. That is a genetic disorder.
Okay.
Like aplastic?
Could be. That I think usually you said the neoplastic.
Aplastic.
Aplastic. So that's a cancer.
Yeah.
Yeah. Usually toxins, to my knowledge. I think there was something about pernicious anemia. Yeah, B12.
Fanconi is the only one I see as an inherited disorder where DNA isn't repaired properly, which can lead to abnormal cells that particularly in bone marrow.
So the biggest problem we have with red blood cells being low in the blood is we're not perfusing our tissues. If tissues are not being perfused, what do we call it?
Ischemia?
better?
Ischemia?
Shock.
Oh.
So, it's anything that leads to tissues not perfusing. So, pre-transfusion checklist, right?
Consent.
Is it ordered? We need to get consent. We need to have a typing screen.
Mm-hmm.
They say 22 gauge. Put something bigger in, but for this class, 22 gauge or bigger. Pre-procedure orders. I don't know. Chlorhexidine scrub down maybe. I don't know why you would do that. It's just blood.
Right.
I don't know.
Mm-hmm. You like vitals? Like
Sure.
trying to get
Yeah.
out of-
Vitals. Yeah.
Pre-medication.
Yeah. Pre-medication. Do they need heparin? Do they need?
Mhm.
Yeah. Yeah, good. Documenting if they have a history of blood reactions.
Mm-hmm.
So if this is someone who has a chronic anemia, you may need to, they may know if they react to blood. Again, immunologic transfusion reactions. The big one we give is acetaminophen and Benadryl. Tylenol and Benadryl. Tylenol? Yeah.
Yep.
What does acetaminophen do? Cool.
Causes autism.
What? It causes autism, that's right. What does Benadryl do? What's diphenhydramine do?
Like prevents like the release of.
Basically, yeah. What's its drug class?
It's
It's
anti-colon.
anticholinergic.
Yeah, Charlie with.
He's a pharmacy
He's a
tech, that's why I
pharmacist.
asked
He's in a
him.
pharmacy. No, this man knows every meg, dude.
Isn't it actually, it's like a beta 2, no, that's not
Is
people.
that
Just
antihistamine?
for, huh?
Is that antihistamine?
It is an antihistamine.
Oh, I'm about to
But
say,
it will-
like, what?
Yeah.
Yeah, I'm scared for a second.
Oh, actually, yeah, you're right. No, it is antihistamine, not an anticholinergic.
Yeah.
Yeah.
And I think, yeah.
So your what's the other word for your cholinergic? So your acetylcholine
Mhm.
is what your anticholinergics are modulating, either the receptors or the production of acetylcholine itself, versus your histamines are your kind of systemic dilatory fight or flight, it's the same thing. Have you ever touched stinging metal? Unfortunately.
Oh, I hate that shit.
Have you ever?
I walked through it one
Brushed
time
up
and I
against
did
the
not
metal?
notice. Mm-hmm. Terrible.
So
Awful.
the bottom side of stinging nettle leaves have all these little needles all over them, and they are full of plant histamines.
Mhm.
They cause an identical, so it's a very local histamine reaction, but it is incredibly painful. Coincidentally, it's also one of my favorite tasty plants out there.
Only you, Ian.
But
Kind of risky.
you have to mash it up real good and break all the needles up, or you can boil it.
Mm.
Don't boil it, because then you break down all the
The good plant juices.
good plant juice. Anyway, so you're gonna piggyback your blood, right?
Mm-hmm.
You have to bookend it with saline. So you're going to hang your normal saline. You are going to run it, prime your tubing with saline. So you have your specific blood filter tubing, right?
Mhm.
And it's that double lumen thing, where 2 lumens come together into the same drip chamber. Prime with saline. Start your blood, and mind you, your blood is on a pump, This is never eyeballing,
Bye, Shania.
later.
Happy Thanksgiving.
Yeah.
I'll put this up on, Discord there as well.
Okay, thanks.
Run your blood at whatever it gets ordered at. It's going to be, do you run blood fast or slow? Good. Why?
Could have a reaction.
Could have a reaction. Good. So, why else might you run it slow, Liz?
I don't know.
There's something that happens when you overload the body with too much blood too quickly.
Circulatory overload?
No, that's fluid. I mean, that could happen, but I'm talking, there's a condition, I can't remember the name of it. What's it called?
You're going too deep.
Going too deep, okay. Thank you.
And we didn't learn it.
Not worried about it.
It was in lab.
Oh, shit. Wow, no.
Yeah, that's what I'm trying to remember. There was something about a condition where if you run the blood too quickly, and
Let's see.
the body reacts to it because it's like, oh, all this wasn't
Don't
here
you get a
before.
headache?
Yeah, one of the symptoms was headache. But then I think it can also start breaking down the blood.
So like hemolytic?
Usually like an
Reaction, is that what you're-
reaction.
Maybe I just mixed it up. Maybe that's what it was. I don't know. Anyway.
Pulmonary edema?
It's just fluid general.
Yeah, it's just saying like fluid
acute
overload.
transfusion reaction.
Mhm.
Okay, good. So then as soon as the bag of blood is done, you immediately reopen the saline to flush the blood out of the tubing.
Mm-hmm.
And then that's that. This blood administration requires 2 RNs, always. Whether you're in the ER, whether you're on the ambulance, whether you're wherever, it's 2 providers. There must be 2 people administering blood. You are going to go through a full checklist. It's extensive. You are going to be checking that the patient is who they are multiple times. You're going to be checking that the blood is the correct blood, that the tech who went up and got it did not go to the cafeteria and get different blood or something. Yeah, it's got to be the right blood. And then your vital signs are going to be very closely monitored. What is a vital sign that might indicate you're about to discontinue your infusion?
Temperature, blood pressure?
Sure, yeah, temperature, blood pressure. This is everything I just talked about. Why pump with filter, use pump, slowly, 20 to 60 mLs. I don't think we're gonna be tested on the specific rate.
Probably not.
But you must remain at the bedside. You're not gonna leave. You're not gonna go do any other patient. You are now one-to-one with that patient for 15 minutes. So after the first 15 minutes, as long as there's been no reaction, then that prescribed rate goes into effect. So you're gonna change, you actually reprogram the pump and get it going at the prescribed rate. So 15 minutes, super slow. We're checking vitals. Has anything changed? Do they look like they're having an allergic reaction? It's gonna be hypotension, fever, urticaria, rashiness, and all that.
Can they get itchy? Is that?
Yeah, sure.
Okay.
Yeah, it's literally an allergic reaction. It's
Right,
it's
okay.
exactly an allergic reaction. We call them an infusion reaction, but it's the same cascade that happens with an allergic reaction. There's a protein that the body doesn't like, mounts an immune response, it dilates everything, crashes your blood pressure, and you run the risk of going into shock. So most hospitals say every 30 minutes, 15 to 30, where at least Chester County, but 30 to 60. Blood cannot be unrefrigerated for more than 4 hours. Just, you can't leave it out of room temp. Think of it like raw meat. You can't leave raw meat out. In the culinary world, we call it time temperature abuse. Can't time temperature abuse your blood. Here's your infusion reactions. So you'll see temperature rise. So how might you assess this patient's temperature, Charlie?
High.
But what type of thermometer might you use? You gonna do it orally? You gonna do it rectally? You gonna do it urethral? What's your? Like a temp sensing Foley or something?
No, like I didn't know the specific word. It's not word.
would
So
assume.
oftentimes if they are not perfusing well, right?
Okay.
Their extremities are gonna be cold. You want a core temp. That's my understanding.
But then why would, are you saying you would do like a rectal temp on
I would
them?
do a rectal temp.
I would argue that because if you're giving them physical trauma, I wouldn't.
Oh, that
Would
is a
do
fair
that.
point.
I don't know if I wanna shift them that much.
That's another fair point. Maybe I'll ask Professor Gray that.
There you go.
Yeah. I can see justifications for both.
Mhm.
But I definitely see like the rectal trauma as
Mhm.
being a contraindication for like if they've had a history of like if they have an active bleed,
Mhm.
probably not going to stick anything in their rectum.
Right.
What? Go on. Okay, so the rest of these are just standard mild allergic reaction, anaphylactic, circulatory overload, sepsis, transfusion-related acute lung injury reactions.
Trolley.
This was the one, massive blood transfusion reaction. Someone look that up. That was the one I remembered from class. That was where, so like, we deal with that on the ambulance because we tend to give blood very fast.
Oh, really?
Very fast. Because here's the thing, if you're full of holes, say you got shot or stabbed, you got to get the blood in. Like,
Mhm.
there's no.
Yeah, that's when you're sitting there with a little bulb and you're just.
Oh yeah, no, we have it on pressure bags. It's not dripping. It's like a full stream. We're dumping blood at the
I've done that in traumas where
Yeah.
my whole job is to stand there and just
Oh my
squeeze
God.
as fast as I
Squeeze
can.
What?
keep the pressure bag up. So.
Do you know to watch for like blood grouping compatibilities?
Yeah. Mm-hmm. So on the ambulance, we'll usually use like O negative blood. I think O negative, O positive, O negative, O negative. So we're not really that worried about it, but O negative blood is rare, and we prefer to use when you're in the hospital, the patient's actual blood type.
It says that the major or massive blood transfusion reaction is just like it's immediate
It's
that you
immediate.
see all
Okay.
these signs.
Yeah.
All right, bye.
Later.
Happy Thanksgiving.
So this says save the blood bag. So
For a reaction, yeah.
So there are vials, there's like parts of tubing that are pre-sealed that you can cut off, and then there's stickers on the bag that you can stick to those little vials. So you don't actually have to save the whole bag, you can just save the little pinched off pieces of tubing. It's like, it looks like a sausage, it's just a bunch of little pieces of tubing. You just put a sticker on each one of those, and you can save the little tiny tubes. Though I've actually never seen that done. I've not been present for a an infusion reaction, so. That's just my understanding of why they have all those little, sausages of blood. Um, He's also had VAD. Has anyone seen a VAD patient before?
Put it in.
Yeah.
Mm-hmm.
We have a new VAD patient in Chester County. It's kind of neat. So it's a ventricular assist device.
Mhm.
It's when you have
So many LVADs.
Yeah. So, basically it's a heart replacement. It's an artificial heart. And big, if you're trying to mess with like a new tech or a student or something, the best thing, the most fun
Get the
thing you can
magnet.
do is tell them, hey, go get me a manual blood pressure on that patient. And they'll be there for 15, 20, 30 minutes going. And then you tell them, give me a pulse. They won't have a pulse. They will not have a palpable blood pressure.
Mm-hmm.
They will not, like, because there's no beating, right? It's a motorized pump, literally just whirring away.
Mm-hmm.
So if you auscultate, you will hear a slight mechanical, the pump's outside, but there's a pump outside or just the box? No, the pump's outside because,
The box is outside and the wires are inside.
right.
Hopefully.
That's scary.
She didn't mention anything about that, so we don't need.
I don't remember, like, I'm looking at it, and I don't.
She talked about VADs, but we didn't really.
I know
Just
it is.
know that it's an artificial heart pump. That's
I
all.
don't-
Like,
I
and
think this is a different kind of VAD though.
this is a CVAD.
I think this is talking about venous access
Yeah.
devices, not ventricular assist devices.
Yes. Yes. Because this is.
Oh.
I was gonna say, I
venous
don't-
access devices. Oh man.
That was
Okay.
almost.
You almost went way off the mark.
Whoa.
You said,
Alright.
let me sit down for this.
Shows how close I read this.
Yeah, I think LVADs and ventricular.
Yeah, I was
assist
like, this.
devices
I
go
don't
beyond
remember
the
looking
scope
at any of this.
Yeah.
I was like,
I had to learn about it in EMT school, and that's well beneath this. So I kind of, when I saw VAD, I was like, okay, let's talk about VADs. Okay, venous access devices.
Yeah, I probably should change one of the acronyms, huh?
Yeah.
These are just central catheters, like, I don't think
Mhm.
anyone calls them VADs.
No.
It's like, oh, they have a central line, or a PIC, or like,
Yeah,
you'll just call it what it is, you're not gonna ever hear these things called VAD in the
No.
hospital.
ever. I'd be kind of mad if they put the term VAD on a test. I would contest ever looking the Jesus out of that.
Mm-hmm.
Okay, so, what can happen if a central line creeps too deep?
Upsets your heart
It
rhythm.
very much does. So, what is incredibly important to document when you do your head to toe for someone with a central line? Charlie?
check for like flushes.
Okay, what else? More important, well, just as important as that.
Patient response.
Blood
Liz?
return.
Marker of
Blood return.
like the depth, or like
Depth.
how much you have of the catheter.
Yes, so you are looking at so there's gonna be demarcations, and it needs to, in the chart, it should say what measurement the catheter's at,
Mm-hmm.
and it should not change.
It's like NG tubes.
Correct. Because if it creeps too deep, it can stimulate, correct, it can stimulate the baroreceptor in the apex of the heart, sending you into VTAC, which we'll, I assume, go over next semester. And if it creeps too far back, you can dislodge it.
I had to guess.
You have to guess. I love it. Mention my name, you get a good seat. So this is a port. We all got to see a port in lab.
Oh, yeah,
They're ports. They're fine.
they're there.
This is a port needle here.
Is this the one that has like the specific needle for it?
Yes, it's like a hooked needle.
Yeah.
I
I don't remember what it's called.
don't know. We don't use it in the ER.
Okay.
So it's considered a sterile procedure to access a port, just because of how invasive it is to get the port in the first place.
Right.
Generally speaking, in all but the most extreme circumstances, we will not use a port in the ER. Unless the port's already accessed. Even then, generally, the guidelines is don't touch it.
Yep.
Unless you need to. So, complications we need to know. We already talked about migration. We did not talk about embolism or pneumo. I'll get to those in just a hot second. Catheter occlusion could be from, again, drifting or from clotting. And then infection, that's pretty obvious. It's a foreign body introduced into the heart. That's a phenomenal access for bugs. So, how might you wind up with an embolism or pneumo? John?
Like air.
Okay. Any other thoughts, Liz?
There's a clot.
Yeah, that would cause an embo. You run this tubing basically through the, around the outside of the pleural cavity, into the, I don't think it enters the pericardium because you're accessing, again, too deep, never mind. But, pardon?
Is it the subclavian?
For the subclavian, that's what I'm thinking about, yeah. For the subclavian, you're accessing that left return side of the vena cava, that lower vena cava.
So I heard like if you get like an embolus, you just like lie down on your left side.
That sounds right. Yeah. Most things in nursing are lay on your left side. Especially if you're pregnant.
Yep. Or if you have GERD.
Every pick will have a sterile cap. They do not go back in bed until you put the cap back on. It's a colored cap, usually fairly brightly colored. Inside is a cotton swab full of chlorhexidine and alcohol. I don't understand why it says Valsalva if no clamp. What does that mean?
If
I'm gonna not clamp but I'm gonna have them bear down and push.
maybe if, I don't know, if it's dislodged and they need to take it out, I don't know.
Oh, no. Okay. They're talking about the lure lock port. So this portion, so not the blue cap, but this, like the actual connect, let me block. Oh. Connected. So these things. So
Mhm.
just this purple part down here. So yeah, that looks like it. Or these. These are the ones we have.
Mm-hmm.
No, there's another threaded. I can't quite find it. I know it's a ones I'm familiar with, or BD something or other. I used to know. Anyway, they look pretty similar. Oh, wait, that's not. Yeah, so there's a small threaded end. So if this, oh, that's not quite it either. Anyway, so there's the thing with the rubber stopper in it that auto occludes the cap, essentially.
Mm-hmm.
When that needs to be replaced, you need to either clamp the tubing, or I think what they meant by Valsalva is you can get their blood pressure to locally drop around the heart by having them bear down, and then as soon as they breathe out, you swap the cap off, because it's going to be at a lower pressure, so
Right.
it won't bleed as much.
So maybe it's.
I think that's a
it's
little,
like a backup.
yeah, I think that's a little outside of what we need to know realistically, but it was in there, so. Flushing. Oh, why do we use a 10 ml syringe and not like a 5 or a 3?
Because it needs to travel.
Hmm?
It has to do like something with like the pressure.
No. What'd you say?
Has to travel.
Has to travel. The total volume, because the tubing's quite long. If you look at how long this catheter is here, or this catheter here, you have to flush this entire tube. The total capacity of that tube may be 3 mLs.
Mm-hmm.
You, to effectively clear everything out, you need a little more than that just for margin of safety. So, you know, if you were administering a medication through there, there's not like a little bit of that medication still left in there that could slowly leak in and affect, or that they weren't getting their full dose of meds. So, especially with the PICs, where it's coming all the way down their arm and it has to go all the way up into their heart. It's you need to be making sure those are very thoroughly flushed. What's Helen say? Oh, that's just a lot of text.
I'm not reading that.
I'm not
Too
reading
much.
it. I'm gonna put that into notebook and have it read it to me.
Like it's infuriating that it's like you go to hone it and they just inundate you with way too much information.
Way too much. It's
Then you go to ATI and they're like, here's 5 bullet points on this entire thing. And you have to just infer. And it's just like, can I be fucking in between? Like, you just tell me what I need to know.
I feel like these would probably be good to look at for studying purposes.
so what I would like. So these kind of remind me of like when I did my EMT and my A. We have it's a performative final. So you actually have to perform patient care on a simulated patient, and it's a live person.
Mm-hmm.
We get a makeup artist to come in and actually moulage the patient's out. It's wonderful. And then you have an evaluator with a sheet of paper almost exactly like this one. And they sit there and you are supposed to demonstrate the ability to perform whatever skill is indicated for that station, and you're told what station it is ahead of time. And if you screw anything up, then you don't pass.
Mm-hmm.
And if you do, good job, high five, move on to the next station. And that's what this feels like. It feels like you're going through a simulated blood administration.
Mm-hmm.
So, I always found these super useful, but I don't know how useful it'll be for the test. Okay. Are we all kind of cooked?
Mm-hmm.
I'm a little cooked.
Mm-hmm.
I need breakfast. Okay.
Yeah.
Good job, fam.
Yay. 2 more classes, guys.